Welcome you. Today we're going to see about cardiac catheterization. Cardiac catheterization is a passage of catheter through peripheral arteries or veins into cardiac chambers, the pulmonary artery and coronary arteries and veins. Cardiac catheterization can be used to do various tests including angiography, intravascular ultrasonography, measurement of cardiac output, detection and quantification of shunts, endomyocardial biopsy, measurement of myocardial metabolism. These tests define coronary artery anatomy because cardiac anatomy, cardiac function, and pulmonary artery hemodynamics to establish diagnosis and help select treatment. Cardiac catheterization is also the basis for several therapeutic intervention. Procedure: patient must fast for 6 to 8 hours before cardiac catheterization. Most patients do not require overnight hospitalization unless a therapeutic intervention is also done. Left heart catheterization. Left heart catheterization is the most commonly used to assess coronary artery anatomy and presence of coronary artery disease. Left heart catheterization is also used to assess the aortic blood pressure, systemic vascular resistance, aortic valve function, mitral valve function, left ventricular pressure and function. The procedure is done via femoral subclavian radial and brachial artery puncture with the catheter passed into the coronary artery ostia and or across the aortic valve into the left ventricle. Catheterization of left atrium and left ventricle is occasionally done using transeptal perforation during right heart catheterization. Right heart catheterization is most commonly used to assess the right atrial pressure, right ventricular pressure, pulmonary artery pressure, and pulmonary arterial occlusion pressure. Pulmonary artery occlusion pressure approximates left atrial and left ventricle end diastolic pressure. In seriously ill patient, PaOP helps assess volume status and with simultaneous measurement of cardiac output can help guide therapy. Right heart catheterization is also useful for assessing cardiac filling pressure, pulmonary vascular resistance, tricuspid or pulmonic valve function, intracardiac shunts, and right ventricular pressure. Heart, right heart pressure measurement may help in diagnosis of cardiomyopathy, constrictive pericarditis, and cardiac tamponade when non-invasive testing is non-diagnostic, and it is an essential part of assessment for cardiac transplantation or mechanical cardiac support. The procedure is done via femoral subclavian internal jugular or antecubital vein puncture. A catheter is passed in the right atrium through the tricuspid valve into the right ventricle and across the pulmonary valve into the pulmonary artery. Specific tests during cardiac catheterization: angiography, injection of radiopaque contrast agents into the coronary or pulmonary arteries. The aorta and cardiac chamber is useful in certain circumstances. And digital subtraction angiography is used for non-moving arteries and for chambers in angiography. Coronary angiography via left heart catheterization is used to evaluate coronary artery anatomy in various clinical situations, as in patients with suspected coronary atherosclerotic or congenital disease, valvular disorder before valvular replacement, or unexplained heart failures. Pulmonary angiography via high right heart catheterization can be used to diagnose pulmonary embolism, intraluminal filling defect, or arterial cutoff or diagnostic. Radiopaque contrast agent is usually selectively injected into one or both pulmonary arteries and their segments. However, computed tomographic pulmonary angiography has largely replaced right heart catheterization for diagnosis of pulmonary embolism. Aortic angiography via left heart catheterization is used to assess the aortic regurgitation, coarctation, pattern ductus arteriosus, and dissection. Ventriculography is used to visualize the ventricular wall motion and ventricular outflow tract, including subvalvular, valvular, and supravalvular region. It is also used to estimate the severity of mitral valve regurgitation and determines its pathophysiology. After left ventricular mass and volume are determined from single planar or biplanar ventricular angiograms, end systolic and end diastolic volumes and ejection fraction can be calculated. Coronary artery flow measurement. Coronary angiography shows the measurement, presence, and degree of stenosis, but not the functional significance of the lesion, or whether a specific lesion is likely to be causing symptoms. Extremity thin guideways are available with pressure sensors or Doppler flow sensors. Data from these sensors can be used to estimate the coronary artery blood flow, which is expressed as fractional flow reserve. Fractional flow reserve is the ratio of maximal flow through the stenotic area to normal maximal flow. If the fractional flow reserve of less than 0.75 to zero point 0.8 is considered to be abnormal. These flow estimates correlate well with the need for intervention and long-term outcome. Patients with lesion with FFR with greater than zero point 0.8 do not seem to benefit from placement of a stent. These flow measurements are most useful with intermediate lesion and with multiple lesion. Intravascular ultrasonography, miniature ultrasound transducer on the end of coronary artery catheter can produce images of coronary vessels, lumina, and walls and delineate blood flow. Intravascular ultrasonography is being increasingly used at the same time as coronary angiography. Optical coherence tomography. Optical coherence tomography is an optical analog of intracoronary ultrasound imaging that measures the amplitude of backscattered light to determine the temperature of coronary plaque and can help determine whether lesions are at high risk of future rupture. Test for cardiac shunts. Measuring the blood flow, blood oxygen content at successive levels in the heart and great vessels can help determine the presence, direction, and volume of central shunt. The maximal normal difference in oxygen content between structure is as follows. The pulmonary artery and right ventricle are 0.5 milliliter per deciliter. The right ventricle and right atrium with zero point 0.9 milliliter of deciliter. The right atrium and superior vena cava is 1.9 milliliter per deciliter. If the blood oxygen content is in a chamber exceed that of a more proximal chamber by more than these values, a left to right shunt at the level is probable. Right to left shunt are strongly suspected when left atrium and left ventricle of arterial oxygen saturation is low and does not improve when pure oxygen is given. Left heart or atrial desaturation plus increased oxygen content in blood sample drawn beyond the shunt site on the right side of the circulation suggests a bidirectional shunt. Measurement of cardiac output and flow. Cardiac output is a volume of blood ejected in the heart per minute. Technique used to calculate the cardiac output include fixed cardiac output technique, indicator dilution technique, thermodilution technique. With the fixed dilution technique, cardiac output is proportional to oxygen consumption divided by artery venous oxygen difference. Dilution technique rely on the assumption that after an indicator is injected into the circulation, it appears and disappears proportionally to cardiac output. Endomyocardial biopsy. Endomyocardial biopsy helps assess the transplant rejection and myocardial disorder due to infection or infiltrative disease. The biopsy catheter can be passed into the either ventricle, usually the right. 3 to 5 samples of myocardial tissue are removed from septal endocardium. The main complication of endomyocardial biopsy, cardiac perforation, occurs in 0.3 to 0.5% of patients. It may cause hemopericardium leading to cardiac tamponade. Injury to the tricuspid valve and supporting chorda may also occur and can lead to tricuspid regurgitation. Contraindication to cardiac catheterization. Relative contraindication to cardiac catheterization include acute kidney injury, chronic kidney disease, coagulopathy, fever, systemic infection, uncontrolled arrhythmia, uncontrolled hypertension, uncompensated heart failure, radiopaque contrast agent allergies in patients who have not been appropriately pre-medicated. Relative contraindication balance the urgency of the procedure and the severity of the contraindicating disorder. Peri-procedural management of anticoagulants or antiplatelet drugs is individualized based on the type of procedure, the urgency of the procedure, the indication of the drug, and the patient's risk of bleeding. Catheterization laboratory frequently have policies for the peri-procedural management of these drugs. Complication of cardiac catheterization. The incidence of complication after cardiac catheterization ranges from 0.8 to 8% depending on the patient's factor, technical factors, and the experience of the operator. Patient factors that increase the risk of complication include increasing age, heart failure, valvular heart disease, peripheral arterial disease, chronic obstructive pulmonary disease, chronic kidney disease, and diabetes. Most complications are minor and can be easily treated. Serious complications are rare. Mortality rate is 0.1 to 0.2%. Myocardial infarction and stroke may result in significant morbidity. Incidence of stroke is higher in patients with greater than 80 years. In general, complications involve the contrast agent, effect of the catheter, and the access site. Contrast agent complication. Injection of radiopaque contrast agent produces a transient sense of warmth throughout the body in many patients. tachycardia, a slight fall in systemic pressure, an increase in cardiac output, nausea, vomiting, and coughing may occur. Rarely, bradycardia occurs when the large amount of contrast agent is injected. Asking the patient to cough often restores normal rhythm. More serious reactions include allergic type contrast reaction, contrast nephropathy. Allergic reaction may include urticaria and conjunctivitis, which usually respond to diphenhydramine 50 mg IV, anaphylaxis with bronchospasm, laryngeal edema, and dyspnea are rare reaction. They are treated with inhaled albuterol or subcutaneous 1 is to 1000 epinephrine, 0.3 to zero point 0.4 ml. Anaphylactic shock is treated with epinephrine and other supportive measures. Patient with history of allergic reaction to contrast may be pre-medicated with prednisone and diphenhydramine. If patient requires imaging immediately, they can be given diphenhydramine 50 mg orally or intramuscular 1 hour before injection of contrast and hydrocortisone 200 mg IV every 4 hours until imaging is completed. Contrast nephropathy is defined as the impairment of renal function within 48 to 72 hours of IV contrast administration. For patients at risk, use of lowest possible dose of low osmolar or isoosmolar contrast, avoidance of multiple contrast studies within a short period of time, and infusion of total 10 to 15 ml per kg normal saline IV beginning 4 to 6 hours before angiography and 6 to 12 hours after reduces the risk substantially. In patients at risk of impaired renal function, assess serum creatinine of 48 hours after injection of contrast. Catheter related complication. If the catheter tip contacts the ventricular endocardium, the ventricular arrhythmias commonly occur, but ventricular fibrillation is rare. If it occurs, direct current cardioversion is administered immediately. Disruption of the atherosclerotic plaque via the catheter can release a serious shower of atheroembole. Embole from the aorta may cause stroke or nephropathy. Embole from the proximal to distal coronary arteries may cause myocardial infarction. Coronary artery dissection is also possible. Access site complication. Access site complication includes bleeding, hematoma, pseudoaneurysm, arteriovenous fistula, and limb ischemia. Bleeding from the access site may occur and usually resolves with compression. Mild bruises and small hematomas are common and do not require specific investigation and treatment. A large or enlarging lump should be investigated using ultrasonography to distinguish hematoma from pseudoaneurysm. A bruit at the site suggests a AV fistula which can be diagnosed using ultrasonography. Hematomas usually resolve with time and do not resolve require specific therapy. Pseudoaneurysm and AV fistula usually resolves with compression. Those that persist may require surgical repair. Radial artery access is in general more comfortable for the patient and carries a much lower risk of hematoma or pseudoaneurysm or AV fistula formation when compared with femoral artery access. Thank you.